Welcome again to the monthly teaching case by NephroTube. This month we have a case of an old age male with painless hematuria and raised serum creatinine. I will start by the history of the patient. Day 1, the patient who presented to us was a 70-year-old man. He presented to the emergency department with progressive fatigue for the past 4 weeks and a painless hematuria for 1 day. His past medical history is remarkable for hypertension, diabetes, bronchial asthma, benign prostatic hyperplasia, and ischemic heart disease. His medication list includes omeprazole, gliclazide, diltiazem, isosorbide mononitrate, aspirin, atorvastatin, tamsulosin, and a basal bolus insulin regimen. His vital signs on presentation are as follows. Hypertension, blood pressure was 170/70. Heart rate is slightly bradycardic, but it was regular. Respiratory rate was 16. Oxygen saturation was good, and his temperature was good also. Physical examination is remarkable for dry oral mucous membrane. Heart, lung, abdominal, and neurological examination was totally normal. No skin rash or joint swelling or lower limb edema. So the positive data from the presenting history are as follow. Progressive fatigue for the past 4 weeks and 1 day painless hematuria. His hypertensive diabetic ischemic heart. On some medications, clinical examination showed only that the patient is hypertensive. On admission, his lab investigation showed the following. Regarding the positive data, he was anemic, hemoglobin 10.6, serum creatinine 3.9 milligram per deciliter. 1 month ago, the creatinine was normal. He was following up his creatinine level as he was hypertensive, as I mentioned. So we are facing a case of acute kidney injury. Blood urea nitrogen 39 milligram per deciliter, slightly hyponatremic. CRP was high. ESR was high. Urine analysis showed 2+ blood and 2+ proteins. The urine protein creatinine ratio was also high, 2000 milligram per gram. His ultrasound abdomen and pelvis was completely normal. Chest X-ray was also completely normal. Other electrolytes was normal. Virology was negative, and the procalcitonin was also normal. So our first question is, please share your opinion in the question. What is your next step in this patient? Order immune markers and do kidney biopsy. Start immunosuppressive therapy and postpone kidney biopsy. Just wait and see. The causes of hematuria is probably non-glomerular, and urology consultation is mandatory. I will give you some seconds so that all of the attendants can participate in the poll. Okay. Okay, I will end the poll now, and I will share the results with you. Okay. As you can see, most of you selected to order immune markers and do a kidney biopsy. Minority will start immunosuppression. Minority will just wait and see. and the minority will see that the hematuria is of non-glomerular origin. Okay, I will now, before telling you what we had did with our patient, I will go at first through practical clinical approach or algorithm for diagnosis of patients with red-brown colored urine. If you have a patient with a history of red-brown or brown colored urine, first of all, the first step is to check urine dipstick and urine microscopy. If the urine dipstick was negative for blood and the RBC and the microscopy was also negative or is also negative for RBCs, so the red-brown color of the urine is not a hematuria, but it may be caused by dyes, drugs, or other causes. For example, consumption of food dyes, some drugs may change the color of the urine, and other causes. If the dipstick showed positive blood but negative RBCs on microscopy, so this is not hematuria. It may be hemoglobinuria or myoglobinuria. So the hemoglobin in urine or myoglobin in urine give the urine the red color, but as they are not RBCs, will not find on microscopy RBCs. So it is either myoglobinuria or hemoglobinuria. If you found positive blood on dipstick and the positive RBCs on microscopy, so this is true hematuria. So first step for patient with red colored urine, you have to check, is it true hematuria, or it is hemoglobinuria or myoglobinuria, or red-brown color caused by drugs or dyes or others. For step 2, if it is true hematuria, you have a positive dipstick and the positive RBCs on microscopy, you have to go to step 2. Step 2, before going into depth for investigation about the cause of hematuria of the patient, you have at first to ask about antiplatelet agents, anticoagulants, cyclic hematuria in females for endometriosis, if there is a history of sickle cell, and the causes of transient hematuria. Regarding antiplatelet agent and anticoagulants, if the patient is on antiplatelet agents or anticoagulants, and if they are the cause of the hematuria of the patient, usually there is a history in these patients of bleeding from multiple sites, not only hematuria. You can find, for example, bleeding from the nose. The second, if a patient has visible hematuria and he is on high dose of anticoagulation, example INR more than 3 for patients on warfarin, so the anticoagulant should be stopped and discontinued, and the patient should be closely monitored for complete resolution of hematuria. When the hematuria resolves after the anticoagulant is stopped, it is still essential to do comprehensive evaluation for these individuals to determine the underlying cause of hematuria if the hematuria persists after the stoppage of the warfarin. Don't forget that we have also what is called anticoagulant-related nephropathy for patients on warfarin. Okay, regarding cyclic hematuria, as I mentioned, if the patient has female patient that always have hematuria, monthly hematuria, and which is related to menstruation, so hematuria that during or immediately after menstruation may suggest endometriosis for the urinary system. Sickle cell traits also may lead to papillary necrosis or renal medullary carcinoma. So if you are treating a patient with sickle cell traits, this may be the cause of hematuria. Causes of transient hematuria, you have to ask about them, but usually hematuria in these patients asymptomatic and microscopic. It wouldn't be macroscopic as in our patient that I will show you his history now. But in general, what are the causes of transient hematuria? Menstruation, acute trauma, recent instrumentation as catheterization or cystoscopy, or vigorous exercise. You have to ask this for microscopic hematuria. If the blood sample was taken while the patient was in menstruation, you have to repeat urine analysis after 1 to 2 weeks after menstruation. History of trauma, repeat urine analysis after 6 weeks. History of recent instrumentation, repeat the urine analysis after 1 to 2 weeks. History of vigorous exercise, repeat the urine analysis after 4 to 6 weeks of no exercise. If after the repetition of the urine analysis you still have hematuria, so you have to proceed further evaluation for this persistent hematuria. So after exclusion of these causes, you have to ask yourself, are there any visible blood clots in the urine? Or does the patient have acute onset unilateral flank pain? If the patient has hematuria with visible blood clots, this is usually non-glomerular bleeding. It is not common for glomerular bleeding with glomerulonephritis to present with blood clots, because blood clots are indicative of heavy focal bleeding, which is usually related to urological extraglomerular cause. The second point, you have to ask, does the patient have acute onset of unilateral flank pain? The presence of unilateral flank pain with the hematuria is more suggestive of a urological cause than glomerulonephritis. Acute onset of unilateral flank pain is suggestive of papillary necrosis or kidney stones. Also, urinary tract infection may be associated with pyelonephritis, may also be associated with flank pain. Ruptured cyst in autosomal dominant polycystic kidney disease may be associated with unilateral flank pain. Finally, the only glomerular disease that may present with flank pain is IgA nephropathy. Some cases with IgA nephropathy may present with flank pain radiating to groin due to stretching of the kidney capsule. However, the pain that is associated with IgA nephropathy is typically less intense than the pain experienced, for example, with kidney stones for renal colic. So the presence of loin pain or flank pain with hematuria is highly suggestive that the origin of the hematuria is non-glomerular. Our patient, the history of the patient that I showed you in the previous slides, the patient was complaining of painless hematuria, and there were no blood clots in the patient hematuria. So it is, and the patient was not on any antiplatelet or anticoagulant drugs, and there is no history of any cause of transient hematuria. If the patient has any of these visible blood clots or unilateral flank pain, urgent urology referral and imaging, for example, CT or ultrasonography, are mandatory. If no visible blood clots in the urine and the patient has no acute onset unilateral flank pain, ask yourself if any of the following is present. Symptoms of urinary tract infection like dysuria, frequency, if there is urine or white blood cells, or if in the urine analysis there is positive urine nitrite. If no of these are present, so we excluded infection because infection may be the cause of hematuria. So we are searching about infection. If there is no evidence of infection, we will go to step 3 that I will show to you in the next slide. But if there is any evidence of urinary tract infection, urine culture should be done to exclude urinary tract infection. If the urine culture is negative, for example, you have white urine white blood cells in the urine analysis, but the culture is negative. In this situation, the presence of white blood cells in absence of infection and in the presence of hematuria, white blood cells may be an indicator of active immune system or immune system activity in the kidney and the glomerular disease. Biuria in absence of infection in a patient with evidence of hematuria and the evidence or suggestion of glomerular disease is always suggestive to or is always suggestive of immune hyperactivity in the kidney, as I will show you in the next slide. But if there is an evidence of infection, you have to treat infection, then repeat urine microscopy after 6 weeks from the treatment of infection. If no hematuria, the hematuria is absent after 6 weeks of treatment of infection. No further evaluation is required. If there is persistent hematuria, you have to go to step 3. In our patient, there was no symptoms of urinary tract infection and no suggestive signs or symptoms of UTI. So we went directly to step 3. Now, in step 3, after we excluded in step 2, we excluded antiplatelets, anticoagulants, transient causes. We excluded urinary tract infection. We excluded urological causes. Now, in step 3, we have to document: is the cause of hematuria glomerular or non-glomerular? The presence in urine analysis of red blood cell casts, dysmorphic RBCs more than 40%, or acanthocytes more than 5%, are always diagnostic for glomerular hematuria. I have to mention an important point. We are routinely ordering the dysmorphic RBCs in urine. When you order the lab test dysmorphic RBCs in urine, please write in your prescription to the laboratory to mention the percentage of dysmorphic RBCs, because if the lab documented that dysmorphic RBCs are positive or negative, this is not enough. If the lab report mentioned that dysmorphic RBC is positive, this is not diagnostic for glomerular hematuria. To diagnose glomerular hematuria, you must know the percentage of dysmorphic RBCs. Dysmorphic RBCs must exceed 40% to diagnose glomerular hematuria. Acanthocytes is one type of dysmorphic RBCs, but acanthocytes are the most specific dysmorphic RBC type for glomerular hematuria. If acanthocytes are more than 5% of the RBCs, this is highly diagnostic for glomerular hematuria. And by the way, as I mentioned in the previous slide, the presence of white blood cells in the urine or white blood cell casts in absence of infection in association with hematuria, this is highly indicative of glomerular hematuria. And this is what we are calling active urinary sediment. Active urinary sediment is the presence of glomerular hematuria RBCs, casts, dysmorphic RBCs more than 40%, acanthocytes more than 5%, the presence of white blood cell casts or white blood cells in absence of infection. If no glomerular hematuria, evidenced by no RBCs casts, normal isomorphic RBC, or the dysmorphic RBC less than 40%, so there is no RBCs casts, dysmorphic or acanthocyte. If there is white cells or white cell casts in absence of dysmorphic RBCs, this may be suggestive of acute interstitial nephritis. Okay, but we have to mention that it is not mandatory to diagnose acute interstitial nephritis to find white cell casts or white cells. Acute interstitial nephritis may be diagnosed even in absence of these. If they are not present, so the patient is in need of urology referral. Back to this arm, if the patient has glomerular hematuria, you have to ask yourself, does the patient have proteinuria more than 500 milligram per day, declining kidney function, or evidence of systemic disorder? If yes, you have to evaluate for glomerular disease. How I will evaluate for glomerular disease? We mentioned this in the case of the last month. You have to take drug history, search for constitutional symptoms, and systemic examination to find any systemic symptom or sign that is suggestive of immune reaction, vasculitis, or any autoimmune disease. Then you have to make your initial laboratory testing based upon clinical presentation. For example, if the clinical presentation is suggestive of lupus, so you have to do the laboratory investigations of systemic lupus, ANA and double strand, C3, C4, and so on. If the systemic examination is suggestive of vasculitis, you have to do lab investigation of vasculitis. If the systemic examination is suggestive of antiglomerular based membrane disease, so you have to do the tests, antiglomerular based membrane antibodies. But in the absence of a specific clinical presentation while you are examining your patient, so you have to do these baseline investigations. You have to do C3, C4, ANA and double-strand DNA, ANCA, both C and P ANCA, anti-GPM autoantibodies, and virology test. And if the patient is more or older than 50 years, you have to search for monoclonal gammopathies. You have to do serum urine protein electrophoresis and the immune fixation and serum free light chain. And that's what we did in our patient. In our patient during the examination, there was no specific sign or symptom suggestive for a disease. So we did all these investigations in our patient. Regarding kidney biopsy, as we mentioned before, it is a gold standard. And after getting the kidney biopsy result, you may re-evaluate your patient with more investigations according to the pathology finding. Okay. If the patient has proteinuria less than 500 milligram per day, and there is no declining in kidney function and no evidence of systemic disorder, this is diagnosed as isolated glomerular hematuria if proteinuria is less than 500. The differential diagnosis in this case is Alport syndrome and the IgA nephropathy. And we can add with them also C3 glomerulopathy. And by the way, thin membrane disease is now classified as part of Alport syndrome. So you will find in the recent literature, you will not find a disease called the thin membrane disease. Thin membrane disease is now considered as a subtype of Alport syndrome. If you have a patient of isolated glomerular hematuria, you must to do routine follow-up, test the patient with kidney function and urine analysis every 6 to 12 months. For sure, there is a debate in this point to biopsy or not, but this is not my point in this lecture. Regarding our patient, we mentioned that the patient has hematuria and proteinuria more than 500. The proteinuria was 2000. And I have also to mention that if you have a hematuria with proteinuria, it is probably due to glomerular disease. You are not in need to search for dysmorphic RBCs or acanthocytes. For example, our patient has hematuria, raised the serum creatinine in 1 month from 1 to 3.9, and the proteinuria of 2000 milligram per gram. So I am not in need to search for dysmorphic RBCs, casts, or acanthocytes. For sure, it is a hematuria of glomerular origin diagnosed by the proteinuria and the raised serum creatinine. So if I went back to the first question, what is your next step? For sure, the most accurate answer is order immune markers and do a kidney biopsy. In our patient, we ordered immunology investigations and we started to prepare the patient for kidney biopsy. At night, the serum creatinine of the patient raised to 5.5 milligram per deciliter. At morning, as I mentioned, it was 3.9. Okay. At night shift, the serum creatinine increased to 5.5 milligram per deciliter. And I will ask you now, what would be your next step after the serum creatinine increased? I will show you now the poll question and you answer it. Okay. What do you think? Start immunosuppression therapy and postpone kidney biopsy because creatinine increased? Start immunosuppressive therapy and perform kidney biopsy, just wait and see. Great. I will share the results. As you can see here, I will share the results. As you can see here, most of you selected to start immunosuppression therapy and perform a kidney biopsy. Okay. We started pulse steroid and intravenous cyclophosphamide immediately. We considered this patient as rapidly progressive glomerulonephritis. And the presence of vague constitutional manifestations that the patient complained of, we mentioned in the first slide that there was a number of constitutional symptoms for the past 4 weeks. Vasculitis is highly suggested in these patients. Why? It is well known in vasculitis that the patient has a vague constitutional manifestations, even for months before the appearance of the systemic affection by vasculitis. Even most of the patients refer these constitutional symptoms to be as common cold or something like that. So the presence of constitutional symptoms that are recurrent in attacks for months or weeks before the systemic organ affection is highly suggestive of vasculitis. In day 2, morning, the serum creatinine raised to 7.5 milligram per deciliter. At night, it was 5.5 milligram per deciliter. Day 2 evening, we got the results of our lab studies. Na negative, C3 normal, C4 normal, C-ANCA was positive, and P-ANCA negative, and anti-GBM was negative. And the kidney biopsy was done. And we are waiting for the kidney biopsy. So the coming question is, I will share the question. What is your next step? Continue immunosuppressive. I mentioned that we started steroids and cyclophosphamide. Continue immunosuppression therapy and wait kidney biopsy result. Start plasma exchange and continue immunosuppressive therapy to kidney biopsy result. Stop immunosuppressive therapy and wait kidney biopsy result. Okay, I will end the poll now and I will share the results. Most of you selected to start a plasma exchange and to continue immunosuppressive therapy till kidney biopsy result. Okay. For sure, this is a case of ANCA-associated vasculitis. ANCA-associated vasculitis can be classified in 2 ways. First, it can be classified according to the clinical phenotype, according to clinical disease. This is the old classification. And more recently, it is preferred to be classified according to ANCA specificity, which is called serological classification. The old classification, according to the clinical phenotype, ANCA associated vasculitis was classified into systemic and renal limited vasculitis. Regarding systemic vasculitis, it is classified into granulomatosis with polyangiitis, microscopic polyangiitis, eosinophilic granulomatosis polyangiitis. Classification according to serological specificity, it is classified into PR3 ANCA or MPO ANCA. The old names were C ANCA and P ANCA. Which classification is better to be used and which classification is related more to the response to treatment and the prognosis? Serological classification is preferred. This is preferred than this. It is important to me when I am asking you what is the diagnosis of this case. It is better to me that you will tell me it is C ANCA or P ANCA. Then you tell me it is microscopic polyangiitis or eosinophilic GPE or whatever. This is better to be mentioned. Why? Because in clinical phenotype, there is an overlap between the GPA and MPA in clinical presentation. First point. The second point, the following are related more to the ANCA specificity than the clinical phenotype. For example, the relapse rates. The relapse rate is higher in C ANCA than P ANCA. So it is important to me to know the type of ANCA than the clinical disease. And the clinical outcome is related more to the serological classification. Mortality is higher in P ANCA. So it is important to me, if you mention that it is microscopic polyangiitis, it is more important to me to know it is C ANCA or P ANCA. So the classification according to specificity, which is the serological classification, it is the most one used now. Regarding the clinical feature according to the ANCA specificity, is it C ANCA or P ANCA? The proteinase 3 ANCA, both of them are common in old age, okay? Kidney involvement is more common in the myeloperoxidase ANCA, but if kidney involvement happened in proteinase 3 ANCA, it is mainly present as rapidly progressive glomerulonephritis, as in our patient. Our patient was BR3 ANCA positive. In MPO ANCA, possible presentation regarding kidney involvement is more chronic and showing indolent course, and more likely to be renal limited, but it may be associated also with isolated interstitial kidney disease, and this is very rare. Respiratory involvement more common with proteinase 3 ANCA, and present with nodules, cavitation, and central airway. However, our patient didn't have any of these. The chest X-ray with the patient was clear, and also we did a CT for the patient later on, and it was totally normal. Can you hear me well? My sound is clear?
Yes, we can hear you.
Thank you. MPO ANCA, the respiratory involvement is less common, and it is more common to present with chronic fibrosis, peripheral reticulation, and so on. Upper airway disease is more common with BR3 ANCA and rare with MPO ANCA. And finally, the upper airway disease, as you know, if it is presented, it usually present with destructive lesion as nasal perforation and saddle nose. Okay. The question, when should ANCA-associated vasculitis should be suspected? As I mentioned, ANCA-associated vasculitis should be suspected in any patient with constitutional symptoms and the clinical evidence of glomerulonephritis, especially if it is rapidly progressive, and especially if the constitutional symptoms started to appear months or weeks before the clinical presentation of glomerulonephritis. Important point also to mention that in patients with vasculitis, you have to exclude infection. With clinical presentation of vasculitis, you have to exclude infection and the malignancy, especially bacterial endocarditis, because it is common to find bacterial endocarditis to present in the same picture of vasculitis, also the same for malignancies. Okay. Regarding the selection of management, regarding first kidney biopsy in ANCA-associated vasculitis, when to do kidney biopsy? We have two situations. Situation one, if the presentation of the patient is suggestive of ANCA-associated vasculitis with positive BR3 or MPO ANCA as our patient, and the rapidly progressive glomerulonephritis with low suspicion of secondary vasculitis. Secondary vasculitis, I mean that there is no evidence of infection. Our patient has had normal procalcitonin level and no evidence of malignancy or weight loss and so on. So this is as our patient. Should we do kidney biopsy? Yes, but don't delay treatment. You have to start treatment immediately and perform a biopsy after initiating therapy when possible. Situation two, if the presentation is suggestive of ANCA-associated vasculitis, but the lab investigations were negative, proceed to biopsy and manage according to biopsy result. Induction of treatment, as in our patient, the clinical presentation and the lab investigations are suggestive of vasculitis, so we have to start induction of remission. What are the lines of management in the phase of induction of remission? It depends according to organ involvement. In ANCA-associated vasculitis, if no organ-threatening involvement, rituximab with glucocorticoid or avacopan. Avacopan is not available in Egypt. It is a complement inhibitor, C5 complement inhibitor. It was tried instead of glucocorticoids, and it is a glucocorticoid sparing. Okay, or cyclophosphamide with glucocorticoid or avacopan instead of glucocorticoid. Which is better, rituximab for induction? We are now talking about induction. Rituximab or cyclophosphamide? It depends on some criteria. Rituximab is preferred in the following situations: in children and adolescents, in premenopausal women and men who are concerned about their fertility, because you all know that cyclophosphamide can affect fertility, frail older adults, because these patients are at risk of hemorrhagic cystitis of cyclophosphamide. If glucocorticoid sparing is essential, because the dose of glucocorticoids that is used with rituximab will be lower. In patients with significant prior exposure to cyclophosphamide and you prefer not to use cyclophosphamide again. And finally, in PR3 ANCA. That's why the classification according to serology is important. Regarding cyclophosphamide, when to use cyclophosphamide is used if there is difficult access to rituximab. So the first line is always rituximab, but if there is any contraindication to use it or difficult access to rituximab, you can start cyclophosphamide. This is if there is no organ threatening involvement. But in our patient, there was an organ threatening involvement, which is kidney injury. So if there is organ threatening involvement or serum creatinine more than 3.5 milligram per deciliter, you can start the same, or you can start immunosuppressive intravenous cyclophosphamide with rituximab or intravenous cyclophosphamide with glucocorticoid or avacopan. And for sure, you have to consider plasma exchange. I will bypass the doses of the drugs. So to not make my lecture very long, you can refer to it later. But I want to talk about plasma exchange. Again, when plasma exchange is indicated in patients with ANCA vasculitis, if there is severe kidney disease in the form of serum creatinine more than 3.4, rapidly increasing serum creatinine or dialysis is required, and no alveolar hemorrhage, or if there is diffuse alveolar hemorrhage with hypoxemia, whatever the kidney condition is. If there is severe kidney disease but no alveolar hemorrhage, you have to treat your patient with 7 plasma exchange treatments over 14 days. So you have to make a plasma exchange treatment every other day. But if there is diffuse alveolar hemorrhage with the creatinine involvement, or even, with the kidney involvement, or without kidney involvement, you have to do a daily plasma exchange treatment until bleeding stops. So in our patient, we did 7 plasma exchanges over 14 days. So back to question 3. What is your next step? For sure, يا ريت يا جماعه ما حدش يكتب على البورد لو سمحتوا. What is your next step? Start plasma exchange and continue immunosuppressive therapy till kidney biopsy result. In day 3, we started plasma exchange for a plan of 7 plasma exchange treatments over a maximum of 14 days. We plan to continue pulse steroid for 3 days, followed by oral steroids to be tapered to 5 milligram per day by the 6th month. We plan to continue cyclophosphamide as the patient couldn't afford rituximab price because the patient was treated in private sector. The patient had no insurance, so he couldn't afford the the rituximab. So we started the protocol of cyclophosphamide with glucocorticoids and the plasma exchange. In day 4, we got the biopsy result. This is one of the glomeruli of the patient himself. And I will ask you now, what is your diagnosis? And I will show you the pull, but look well to the biopsy result before I to the slide, before I show you the pull. Now I will show you the pull. What is your diagnosis? Is it membranous nephropathy, membranoproliferative glomerulonephritis, crescentic glomerulonephritis, or normal light microscopy? Okay. Most of you selected crescentic glomerulonephritis, and this is the correct answer. The correct answer is crescentic glomerulonephritis for sure. This is the crescent. This is the cellular proliferation of the parietal epithelial cells. There is no glomerular basement membrane thickening to say membranous nephropathy. The capillaries are open in most of the glomerulus, so it is not, it is mesangial, no, there is no mesangial proliferation, so it is not mesangial-proliferative, okay? In following days, this is the graph of the patient. We started here pulse steroid, followed by oral steroids. We started cyclophosphamide, and we started plasma exchange, as I said. The creatinine of the patient, we said that it raised to 7 milligram per deciliter. With plasma exchange and cyclophosphamide and so on, it decreased gradually till it reached at the end of plasma exchange to 3.5, from 7 to 3.5. But the C ANCA is still positive, even after plasma exchange, cyclophosphamide, and the patient is being on oral steroid. The question now, after you did this induction treatment and the C ANCA still positive, what would be your next step? I will show the poll. Okay. As C ANCA still positive, more plasma exchange treated. The patient had 7 plasma treatments. As C ANCA still positive, more plasma exchange treatment should be considered till get a negative C ANCA. As C ANCA still positive, shift from cyclophosphamide to rituximab. As C ANCA still positive, although plasma exchange, then the patient is considered resistant to treatment and no benefit from starting maintenance therapy. As there is a clinical remission, creatinine is improving, it is mandatory to start maintenance therapy. Okay, I will show. Not all the attendees are sharing in the pool. No problem. Most of you selected that there is clinical remission. It is mandatory to start maintenance therapy. Okay, let's see what is the evidence is saying. Responses to induction therapy. The first, if the patient remained on dialysis, actually our patient didn't need dialysis, okay? But if the creatinine is increasing and after starting induction therapy, the patient remained on dialysis despite 3 months of induction therapy, consider discontinuing immunosuppressive therapy provided that the patient has no extrarenal manifestations. No need for immunosuppression, and the patient is considered totally resistant to the treatment. If the patient remained on dialysis for 3 months, provided that you give the patient induction therapy with full dose. But if remission is achieved on full induction therapy, you found a response of the patient on full induction therapy, as our patient, his creatinine decreased from 7 to 3.5. You have to start immunosuppressive therapy, maintenance therapy. So ANCA positivity at remission, as our patient, the patient had still ANCA positive test, although there is a clinical remission. The persistence of ANCA positivity at remission without clinical signs of active disease is not considered a resistant disease. This is first point. The patient is considered resistant according to clinical presentation as this, that the patient remained on dialysis despite 3 months of induction therapy. The ANCA positivity at remission doesn't require augmentation of immunosuppression, as ANCA titers are unreliable markers of disease activity. Okay, so the most correct answer in this question is, as there is clinical remission, it is mandatory to start maintenance therapy. The question now, what is the first line recommended maintenance therapy for this case? I will show you the poll. I have to stop the results of the previous poll. I'm sorry. Okay, question 6. Select the most accurate answer. What is the first line recommended maintenance therapy? Is it rituximab, azathioprine with low dose glucocorticoid, mycophenolate mofetil, or methotrexate? Okay, I will end the poll and share the results. Most of you selected rituximab. Okay, okay. Regarding the available evidence, always for maintenance therapy, rituximab is the first line. In the induction therapy, we mentioned that rituximab is important in some situations, and if rituximab is not available, we can use cyclophosphamide. For maintenance therapy, rituximab is first line, always first line. Okay, azathioprine with low dose glucocorticoids is the second line for maintenance of remission in case of limited availability of rituximab. MMF or methotrexate, they are used as alternative in patients who are intolerant to rituximab and azathioprine. In our patient, we started azathioprine with low dose glucocorticoids because the patient couldn't afford rituximab. I will not go through the regimens, but there is an important question. When to start maintenance therapy? You finished your induction therapy, when to start immunosuppressive therapy? If you use the rituximab for induction, start maintenance therapy 4 to 6 months after the last rituximab dose, because rituximab will be enough to suppress the immune system of the patient for 4 to 6 months. So there is no need to start immunosuppressive maintenance therapy before 4 to 6 months after the last rituximab dose. If your induction therapy, as in our patient, was with intravenous cyclophosphamide, start maintenance therapy 2 to 4 weeks after the last dose of cyclophosphamide, provided that the white count is high and the absolute neutrophil count is also high. Regarding oral cyclophosphamide, you can start maintenance therapy immediately after the induction phase. So rituximab, you have to wait 4 to 6 months. Intravenous cyclophosphamide, you have to wait 2 to 4 weeks. And oral cyclophosphamide, if it is used for induction therapy, you have to start maintenance therapy immediately. Our patient is discharged on azathioprine 100 milligram per day, glucocorticoid 30 milligram per day, to betaber to 5 milligram per day at the 6 month, and to continue intravenous cyclophosphamide at weeks 0, 2, 4, 7, and 13. I'm sorry, the patient is not discharged on azathioprine. This is what we are planning to give as maintenance therapy after induction with intravenous cyclophosphamide. I'm sorry, it is the patient didn't discharge on azathioprine. This is what are planning to give the patient after maintaining the full induction phase. Okay. The patient serum creatinine at discharge was 2.5 milligram, and the patient was discharged to follow up with us in the clinic to continue the management in the maintenance phase. We are hoping that the patient will recover his kidney function to be totally normal. So that was our case. The main teaching points of today was how to approach a case with hematuria, how to diagnose cases of vasculitis, the importance of serological classification in vasculitis, how to select the most appropriate treatment for vasculitis according to the clinical presentation of the patient, what is the first line of treatment for induction of treatment in ANCA-associated vasculitis, what are the lines of therapy for patients, for maintenance therapy for patients with ANCA-associated vasculitis, the positivity of ANCA vasculitis at the end of induction phase is not always indicator for activity. Thank you for watching the case. The record will be uploaded on NephroTube, inshallah. See you next month with a new case, بإذن الله.